Well, thank you very much, Lindsay. Good morning, everyone. I am honored to be here today to be able to present, and I hope our time together is going to be valuable for you. I also, just getting started here with the presentation, just going to move this box up here. There we go. I also had a land acknowledgement and want to acknowledge the land that we share today. So the purpose of our presentation, this is about an hour-long presentation with time for questions at the end. I'm hoping to just answer some of those general questions around what is obsessive compulsive disorder or OCD, who's affected by OCD, what types of treatments are available, and also hoping to provide some information about resources and supports for individuals who experience OCD and for the people who are impacted by people who experience OCD. I'm sure many of you have heard the term OCD. It has become quite popular on social media. It's become part of our vernacular. It's thrown around very easily. Sometimes you hear people saying, oh, my OCD is showing as they organize things on the shelves or they line things up. Sometimes people say, I'm so OCD as they're cleaning off the counters in the break room and stuff like that. That is not the experience of OCD. That's called being particular. OCD is a much different experience, and when things are used that way, it can start to increase, it can make it more difficult for people with OCD to actually be able to receive treatment and to be able to determine their symptoms. So part of our work today is I'm hopeful that we can develop a greater understanding of what OCD is so that people are able to identify their symptoms and seek out support and treatment, and also so that we can have a greater understanding for the community to build support for them outside, as well as to reduce some of that mental health stigma that sometimes comes up. So thank you for being part of this presentation. Your presence here today is a step towards greater understanding and therefore potential for advocacy. So moving along, what is OCD? Well, there are three main components of OCD as set out by the Diagnostic and Statistical Manual of Mental Disorders, also known as the DSM-5 TR, the revised edition. So what this is a collection of disorders that have listed symptoms and criteria in order to be diagnosed with that disorder, sometimes referred to as the psychiatrist's Bible. So what's set out in the DSM-5 is that there has to be three components present in order for OCD to be diagnosed. So the first one is this presence of obsessions. The second one is the presence of compulsions. And then the third piece is having the impact on your life with these two pieces. So starting off with obsessions, unwanted thoughts, images, and urges that create anxiety or distress for the individual. These are intrusive. They tend to be inconsistent with the person's sense of self-image, with their values or morals. Sometimes the thoughts feel repugnant or disgusting, unacceptable. Sometimes the thoughts lead to really considerable uncertainty and doubt, anxiety. When you have an intrusive thought of this degree, sometimes people start to think, does that mean I would do what I've been thinking? Or this thought prompts the idea of like, if that would happen, how horrible would that be? I wouldn't be able to stand it. It's kind of like having a worry bell that's stuck on and ringing constantly. It's a false alarm that's sounding. So there's different types of obsessions or intrusive thoughts that can come up. Things like being worried about germs, getting sick, dying, worries about bad things happening, worries about doing something wrong, thoughts or images of hurting others, unwanted thoughts or images about sex, feeling that things have to be just right before they can move on. So the second component is that with that distressing experience and the anxiety that comes up with it, there then becomes a compulsion. So this could be a repetitive physical and or mental behavior that an individual feels driven to perform to reduce that distress or that anxiety that they caused by the obsession. So a classic example is the idea of I've touched something and now there's germs on my hand. And that's distracting and distressing for the individual. And so then they feel required to wash their hands repetitively to make sure that the germs have been removed. And they have to do it until it feels just right. So that's one example. Sometimes the compulsion is in the mind of the person. We actually can't see what the action is. So those would be things like repetitive prayer, reciting or repeating certain words or phrases, mental counting, mental rehearsal, mental review, all of those types of things. Other examples that I can come up with or that have been listed here is the washing or cleaning, asking for reassurance or seeking out reassurance from people, starting things over again, making a list again and again, erasing, rewriting, repeating until it feels right, having lucky words or numbers, making things even, doing things in a specific order, checking, touching, tapping, arranging, counting, praying, confessing, and apologizing. So those are just examples. OCD can be quite creative, and so there's many things that could be added to that list, but those are some good overviews. And typically a person becomes quite upset if they can't engage in their compulsion, because in their mind, the compulsion is what's going to bring down the anxiety or the stress that they're feeling from that intrusive image or thought. And then finally, the third component that needs to be present is that the obsessions or compulsions have to be time-consuming or create distress or impairment in functioning. There has to be an impact on their life. So it's quite common for individuals with OCD to avoid certain people, certain places, or things in order to not trigger the thoughts. So an example could be avoiding public washrooms, avoiding attending a party, not being in the kitchen at the same time with another family member. It's common for compulsions to take a considerable amount of time to complete over the course of the day, sometimes needing to be completed over and over again or completed multiple times throughout the day, which then starts to interfere with functioning, with work, with life, with school, things like that. So OCD is considered a biopsychosocial model and a disorder, meaning that there are biological, psychological, and social roots to its presentation. Biologically, we've seen that OCD runs in families and that there seems to be a very strong genetic component to it. We used to think of OCD as primarily an anxiety disorder, but that's now changed and has become separate from in the DSM with its own category. I want to note that OCD is separate from other disorders, but there can be related disorders and overlapping symptoms that happen. So OCD is separate from, body dysmorphia, skin picking, hair pulling, hoarding, some of those pieces, but there are similar elements, and they can be present at the same time. Another piece I want to mention is that there seems to be a very strong bi-relational connection between depression and OCD. So they influence each other in that you're going to hear how challenging OCD can be for people and how it impacts their life and often makes their life and day-to-day functioning restricted. And that then increases isolation, which can increase those depressive feelings. Similarly, if you are already experiencing depression, you can be more vulnerable to OCD thoughts or images coming, these intrusive experiences, and you might have less energy to engage in therapy. So it becomes this bi-directional influence between them. I have an example where I had a client come in, symptoms showing depression. Those were very obvious. It was coming up. That was the key component of why he came in. But when I started to ask questions and nudge in certain ways, all of a sudden we realized that there's this whole OCD intrusive thinking that was really getting in his way and was underlying the depression. So suddenly we have to treat things very differently. So here we have a really great image. This is from Anxiety Canada, which is a website that has some really great resources, and it captures the cycle that happens with these components. So basically we start with this intrusive thought, this image, the urge. It's unpleasant, it's distressing, and there's this big spike in anxiety. The brain connects, if I do this behavior, suddenly the anxiety starts to come down and there's temporary relief. And so the compulsive behavior, that urge to do something specific, brings that temporary relief. However, it then reinforces the thoughts coming in. And so the intrusive thoughts to compulsive behavior connection becomes stronger. So every time a thought comes up, there's now this increase of anxiety and distress. It starts to compound, and there's a stronger and stronger urge to complete the compulsive behavior. So again, some examples of the OCD, the thoughts often fall into these categories of harm, forbidden or taboo thoughts, cleaning, and symmetry. And I have some really great stories and examples that can help to understand how that cycle gets stronger and stronger for people. So I'm going to read from Mike's experience as a teenager. This is from the OCD workbook for teens. I have this listed at the end of the presentation as one of the resources. So for him, let's meet Mike. Mike's parents left early for work, so he was always the last one out of the house in the morning. He had a routine that was pretty simple. Fill the water dish for the cat, turn off the lights, turn off the coffee machine, lock the door, run to meet the bus. While on the bus this morning, the thought popped in his head that maybe he had left the coffee machine on. Well, that doesn't really keep the coffee hot. Nothing to worry about, he thought. But then images of fire started spreading through his mind as he imagined a fire spreading through his home. He texted his mom, who quickly reassured him that the coffee machine turns off automatically after a while anyway. But throughout the day, the images of the home burning, his cat suffering, his family and community blaming him, his life being ruined, just kept hammering him. All was fine in the end, but the next morning, Mike got up extra early to make time for a more elaborate check for the necessary items. He walked from each item to the next one while saying out loud, "This is done. I see that it's done." That seemed to help, and for a few days anyways, until the images of catastrophe started intruding in class. The next day, he added to his checking routine by turning the lights off, then on, then off, then on again to make sure they were working properly and definitely off. This addition to his routine seemed to relieve his distress for some time until he started worrying about whether the door was locked. Images of burglars invaded his mind as he imagined his home being invaded. He pictured his parents yelling at him for his incompetence as they showed him all the empty spots where prized possessions had been. He pictured his cat wandering around in the neighborhood because, of course, the burglars had let him out. Now, the routine needs a strategy for guaranteeing the doors are certainly locked, he thought. Again, this addition. Fast forward a week or two, Mike needs 15 minutes to lock, unlock, relock, take pictures of, and make the right statements about the front and back door of his house. He hates it, but if he doesn't get it feeling just right, he can't function at school. His mind helplessly devoted to telling stories about how one mistake ruined everything. Some days his mind wouldn't let him feel finished enough, so he would miss the bus and make up excuses, like saying he was sick that day. Some days he would try to get his parents to come home from work early to make sure he hadn't made a mistake. Some days he would text them, confessing that he thought he forgot something, demanding they tell him specifically, "You got everything." He often had difficulty concentrating at school. Who cares about Canadian history if my house is burning down? Grades started to slip, and so did sleep. He would lie awake at night, planning his checking rituals, thinking this time they would guarantee freedom from thoughts about it the next day. This one is a really good example of how an initial thought compounded, and his response was to become increasingly more careful and to become increasingly distracted by the intrusive thoughts. I have another example of a client. I've changed all the names, of course. So Claire, she's been driving for years. One day she drives through an intersection, she hits a pothole, and suddenly she has the sense, "Oh, did I just hit a pedestrian?" So she circles back through the intersection to make sure that no one is injured. Oh. However, the next day she drives through the intersection again, and this time she has the thought and an intense image of hitting a pedestrian and then thinking about how horrible that would be. And she experienced intense distress and anxiety. So she felt the need to circle back through the intersection again and again until she was certain no one had been injured. Over a few weeks, the thought and image and the compulsion of circling back through the intersection became so strong and so distressing that she no longer took that route. She avoided that road. However, that is not sufficient, as eventually she starts to experiencing images when she's driving through other intersections. So eventually she stopped driving. In another case with Tom, he had this concern about leaving a digital footprint. So he's worried about leaving evidence on the internet that doesn't reflect the person that he is. So his past searches might reflect a style of music that he's no longer interested in, and that was a very distressing thought for him. So he would feel the need to delete his search history every single time he used the computer. He would need to shut down his browser after every search, and he'd have to at times delete accounts or profiles and set up new accounts with new passwords. And again, you can start to hear how a basic activity like using a search engine becomes distressing and time-consuming. And he would need to do his compulsion of rechecking and shutting things down until it felt right. And how do you know? It was just a feeling that it was okay. And his example is similar to people who have symmetry OCD. And then another example, a client, she has a recurring image of her brother being naked and engaging in sexual acts. So this is horrifying to Amy, and she begins to believe she's a very bad person for getting these images in her mind. And she worries it's not safe for her to be with her brother. So to counter the images, she starts to repeat the statement to herself, "I'm a good person," over and over again, and to neutralize that image until it feels okay. She also starts to avoid spending time alone with her brother, and she starts to believe that she needs to keep him safe by not being around him. Now, that would be an example of the forbidden or taboo thoughts category. So OCD can make you think something terrible is going to happen. It's going to be my fault if it happens. I must be a bad person. I can't stand these feelings of distress or anxiety. That doubt, didn't I? I'm not sure. I need to know for sure that it's okay. Have a certainty about it. I can't make any mistakes. And then that last one of that overwhelm, I don't know what to do. So that gives you a pretty good idea of what the experience of OCD is like. So who's affected by OCD? Well, about 1.1 to 1.8% of the population meets the diagnostic criteria. It's relatively rare in the general population, but it is a more common disorder than some of the other ones in the DSM-5. Interestingly, there's studies that show that 80 to 88% of people have intrusive thoughts. We can likely all relate to suddenly having just like a weird or uncomfortable thought pop into our head. And we go, what was that? That was weird. Perhaps as you're driving, you just have this thought, what would happen if I swerved into oncoming traffic? Maybe you suddenly have an image of your teacher or a coworker naked or engaging in a sexual act, and you go, wow, what was that? But 80 to 88% of people experience these intrusive thoughts at some point in their life. The difference is that while this is a normal human experience of having a weird thought, we move on with our days and quickly forget about it. It's not the thought in and of itself that it's the problem, so much as the response or reaction to the thought. So for individuals with OCD, the thought and the distress that comes with the thought sticks. The thoughts become loud and difficult to ignore, and typically leads to a behavior, that compulsion, that tends to solidify the fear. I need to do this to make sure whatever doesn't happen. So sometimes this is described as a net in our brains. So a closely woven net versus a loosely woven net, with the idea that all of us have these thoughts, but the net's pretty loose and it just passes through and it's allowed to dissipate. We don't have to do anything in response to the thought or the image. With someone with OCD, that net tends to be more closely woven and the thought gets stuck. And this goes back to that biopsychosocial model of why, of the components that influences how tightly someone's net is woven. So again, that genetic link might be present, perhaps their temperament as well, a nurture component of how parents or family members influence them in terms of their own anxiety or their own OCD compulsions. And so these factors can start to make someone's net just a little bit tighter, making it harder for these intrusive experiences to pass through. So OCD actually often begins in childhood with adolescence or early adulthood, with the average age being around 19. About 25% of cases starting at about the age of 14. Interestingly, when I discuss onset with some of my clients, they can often pinpoint moments earlier in their childhood, around the age of 10, where they have some precursor experiences that influence then that development of OCD. There's some slight variation between sexes. Females are often affected at a slightly higher rate in adulthood, while males are more commonly affected in childhood, but truly the gender differences are minor and not relevant for treatment. So as you can see from the examples that I provided, OCD untreated can create significant distress, drastically impact functioning and enjoyment in life, and it starts to impact the people around them. So the first step is actually getting an assessment and a diagnosis. Hopefully this is being done by someone qualified, like a psychologist or a psychiatrist. Typically the Y box is what's used. That's the Young Brown Obsessive Compulsive scale. And completing it will determine if you meet the criteria for the OCD. And it should provide a number that provides the baseline for treatment. And what we're hoping to see is that that number starts to decline with treatment, and you're starting to have that decrease in anxiety. So treatment is important, because without directly addressing the compulsions, a person's world becomes smaller and smaller. Think about Claire, think about Mike, how over time things became more time consuming and more distressing. Also, without treatment, it starts to morph into different areas. It doesn't stay contained. So I have an example of a client, Anita. She had a diagnosis of OCD when she was in high school. That focused around her relationships. She had a lot of social distress. She had lots of mental rehearsing, needing to reach out to friends to reassure herself that they didn't hate her, or that a certain comment wasn't misconstrued. It's very time-consuming, very distressing. Once she received the diagnosis, she was able to engage in some therapy and treatment, gained skills, and really made a significant difference for her. Fast forward, she got into university. She was a couple years into her program, and she had a particular stressful exam period. And all of a sudden, she noticed that she had this really increase in intrusive thoughts that kind of came out of nowhere, but had nothing to do with relationships. Suddenly now, all of her thoughts were focused around her pets, taking care of them, being distressed and concerned for them, fearing that they were going to die or that they were going to be harmed. And she went, where did this come from? It was so different from what she experienced in high school. However, it was still the same concept. She was able to transfer the skills and recognize them as OCD thoughts, use all of her good work, and she was quickly able to get a handle on them and kind of bring down that stress and have them decrease to some degree. And so it's just an example of OCD can be creative. It can come up in lots of different ways and show up in lots of different ways for people. So in terms of treatment, I'm going to focus on this first one, the exposure and response prevention. This has been shown to be the most effective method of treatment. And it's based on the principle of exposing the individual to their distressing thought, image, or urge, and then preventing them from engaging in the compulsion. Basically, they're not able to do the thing that typically brings down their anxiety. They start to learn that the distress that they experience comes down over time without the compulsion. This can take a while. This can take hours. And it starts to weaken that connection between the obsessive thought and the compulsion. We're not targeting the thought, but rather we're preventing that behavior component. Basically, face the fear, but don't fight the thought. So I just have a bit of an outline here on what that would look like. So the exposure is being exposed gradually and thoughtfully to triggers at a doable pace. We want them to be able to manage and handle it with distress, with anxiety, but we're not flooding them, we're not throwing everything at them all at once. So during that exposure, simultaneously, we're reducing and working towards eliminating the compulsions or rituals, including avoidance, distraction, and reassurance seeking. And the goal is that we're decreasing the distress overall, developing a new, more helpful way of thinking and responding to triggers, and then allowing that person to live more according to their own values and their own choices. So thinking back to Anita, the trigger changed for her between high school and university, but the treatment is the same. Oh, I need to sit with this thought. I need to recognize that it's an OCD thought and then not do the thing that at the moment would feel like it would bring down the anxiety. So ERP is challenging. It's a hard thing to buy into sometimes, but when you do it correctly, the following things happen. You have that initial increase in anxiety, uncertainty, doubt, obsessional thoughts. You sometimes have a spike, but then you find that those thoughts and feelings can't hurt you. They're safe and manageable. When you stop fighting the obsessions and the anxiety, these feelings naturally begin to subside. And that drop in anxiety, when you stay exposed and prevent the compulsive response, is typically called habituation. You find that over time, your fears are less likely to come true than you thought. And then you get better at managing that everyday level of risk and uncertainty. So yes, it's hard, it's challenging, but the treatment provides a more lasting relief rather than that temporary decrease. Typically, when diagnosed and engaging in treatment, people feel less alone and they feel like they have choice and a way to respond to this rather than just being swept up by the OCD. And it often creates a lot of freedom for them. So the key elements of ERP, that exposure and response prevention, is first to do a psychoeducational component where you're explaining that cycle, where you're explaining what's happening in the person's body and in their life. However, we only typically do this once, just at the beginning. We don't want the repeating of the education to be acting as a form of reassurance, which would just be a compulsion. We then typically move into creating an exposure hierarchy with the client and sometimes with their family. And this is identifying triggers that have increasing degrees of anxiety for the individual. And these can include things that are just images or videos or in their imagination. It doesn't have to start with being out in the world. So here is an example of a fear hierarchy that was created. Again, this is from the Anxiety Canada website, and it outlines Chris's experience. So Chris is a teenager. He's worried about germs and tends to avoid touching things he thinks are dirty. He's also concerned about coming into contact with germs so he avoids going into public places such as the mall. He washes his hands whenever he thinks he has to come into contact with germs and does it frequently, so his hands are dry and red. He also changes his clothes whenever he returns from being out, since he worries that they're contaminated. So in this hierarchy that he created, sometimes it's called a fear ladder, with the therapist, you can see from step 1 to 13, and then on the other side, the fear rating increases from 3 to 10 plus. So he would be walking through this hierarchy with a therapist over multiple sessions and then practicing at home on his own. The key point is that if Chris normally washes his hands and changes his clothes, he would not be able to do that component, the compulsion piece, and he could only wash his hands before meals, after using the bathroom, and only changing his clothes before bed. And of course, here to note, we don't start on step 13. We always start on the lower range, that 1 or 2. Typically with exposure, we don't always necessarily do it in order 1 through 13. Sometimes we can skip around a little bit, go from 2 to 4, go from 5 to 8 sometimes, and go up and down. But with that gradual process of creating the evidence of moving up and through until finally you're doing some of the things that create the most distress for you. So once you've created the hierarchy, we teach something called RIDE. And it's just an acronym for the ERP. And this is what you're going to do when you're not doing your compulsion. So again, coming here, riding up and down the worry hill, again, just a resource. There might be other acronyms that other therapists use. This is just one that I found to be helpful. The first one is rename the thought. That's OCD talking. That's not me. Insist that you're in charge. I'm in charge. I choose not to believe OCD. I'm going to then defy it. I'm going to ride up and down that worry hill, knowing that the anxiety is going to come up, and until I can coast back down. I'm not going to do the compulsion. In Chris's case, I'm not going to wash my hands or change my clothes. And eventually, over time, you move on and other feelings come and replace it. And so then you have that last part, that enjoy your success, reward yourself. I did it. I beat OCD. I can do it again. And you're weakening that connection between the intrusive obsession and the compulsion, which is the behavior. So then hopefully we can move into doing in-session and at-home exposures where the person is able to engage in that ride. I'm going to mention here with the parenting component, it can be very challenging to parent a child or a teenager who has OCD. It's hard to watch their distress and to see them struggle. And in particular, they want us for their parents to accommodate and to reassure them. And it is important for parents to manage their own emotions because unfortunately, when a parent engages in the child's compulsion, it's actually sending the message that the child's OCD thought is a valid concern. And you start to legitimize their thought and for them to think that it's dangerous. And it starts to become then that the compulsion becomes a necessity. And that's not the message that we want to send. So we'll talk about that a little bit more, but I do want to just acknowledge how challenging parenting can be in those roles when our natural inclination is to make things easier, is to reassure them, is to give them this empathy and compassion. But again, that reinforces that perhaps their fears and concerns are valid. So tolerating your distress as a parent or a partner, and then teaching the person with OCD to tolerate their distress. So we're going to go back to this image, and it outlines a few other treatments as well. So starting in the bottle with mindfulness, again, this is building that skill around distress tolerance. Moving to ACT, or acceptance and commitment therapy, and then finally inference-based cognitive therapy. Typically, these help an individual to tolerate distress and are most effective when used alongside with some degree of exposure in the response prevention. So with mindfulness, you're paying attention to the present moment on purpose without judgment. When we can be mindful, our distress about the moment decreases. We create some distance between what we're experiencing and the distress, and we're better able to accept a thought or sensation as being momentary and holding a position of curiosity toward it. With acceptance and commitment therapy, it works with the person to stay present with themselves in the moment, to accept their thoughts as thoughts, not anything more than that. And to align their actions, their behaviors with their genuine values and beliefs. And it creates choice points, kind of who do I want to be in this situation? And then the inference-based cognitive therapy works on the premise that a false doubt is created by the imagination. ICBT focuses on how the false doubt arises and teaches how to return to the direct, trustworthy experience of reality. It takes that concept where a minor possibility is treated as a high probability. Imagination moves it from a minor to a high probability and being able to work back to the reality of what the situation is. I want to note that insight therapy, that classic talk therapy, can actually make things worse for OCD. It's not about logic. It's not about talking things through or arguing with yourself, and doing so can actually make it worse. We don't need to be interested in where this thought might come from, or if they're meaningful, or if they're reflective of who you are. We're just looking at accepting and tolerating the OCD thoughts and making them less powerful. Kind of that idea of like, just because it's disgusting doesn't mean it's dangerous. So in reflection of these distress tolerance skills, this is good for all of us as parents, as partners, as coworkers, being able to manage our own distress and to function well is helpful for everyone. And it's helpful for teaching these skills to people with OCD. These are general skills that can be utilized. I'm going to walk through them a little bit. The first one being imagery. Oh, I'm feeling really anxious. I'm feeling really distressed. I'm going to visualize. I'm going to be, for a moment, put myself into a different place. What do I see, feel, hear, smell, and taste? It can help to regulate that emotion. Finding meaning in the distress. What can I get from this difficult situation? On the strength that you're going to gain in making through it. Being encouraging. I can be my own coach. I can stand this. It won't last forever. Cheering yourself on. Relaxation, doing something that you find enjoyable, just shifting into a different mindset. Focused attention, that's a little bit of that mindfulness, focusing your entire attention on what you're doing right now and only on what you're doing right now. Another one is accept, the ACCEPT, the first letters, the acronym. Activities. Whew, you have this distressing thought, you have these distressing emotions and feelings. Engage in activity that requires thought, concentration, or movement. Exercise, engage in a hobby, read a book. Contributing, doing something for somebody else, baking cookies, tidy up, take the dog for a walk, do something that feels like you're contributing. Comparisons, we're going to put things into perspective by comparing how you felt the last time when you had this feeling. Maybe you're actually doing better than other times. Think about how far you've come, how you've been able to move through your obsessions. Emotions, try to create a competing emotion. Listen to music, watch funny movies, scroll for funny in memes, things like that. Pushing away. So in this one, it's containing what the feeling or experience is, lock it away for time, put it in a box, that idea. Thoughts, doing a mental activity to shift your thoughts to something more neutral. Sing in your head, count back from 100, do multiplication, times tables, word puzzle, Sudoku. My one caveat with all of these, though, is that if you're a person who's experiencing OCD, making sure that your distress tolerance skill isn't becoming a mental compulsion or becoming a compulsion. We're not doing distraction or avoidance. You still want to acknowledge the intrusive thought. You still want to call it out as OCD, recognize what's going on, but then you're putting your energy and your focus onto something else rather than engaging with the thought. Again, facing the fears, not fighting them. So, exposure response prevention therapy with those other ones alongside of it can be very effective. But what is not helpful for OCD? Well, denying that it's present. Again, that logic of trying to argue with OCD, providing advice to someone with OCD. That reassurance piece is actually feeding into it rather than helping it. Distraction and avoidance can become a compulsion rather than being helpful. Engaging with someone and being skeptical or not trusting what they're saying or what they're experiencing doesn't help them. Unfortunately, accommodating someone with OCD is also not helpful. Blaming or shaming, punishment, that does not work for the person. It does not help them to change things. And surprise changes can really throw someone off who has OCD. So those are some of the treatment options that are available for people who want to seek out help. But this disorder does affect the people around someone with OCD. And it's important to understand what the impact is for families. Oftentimes, if you have a family member with OCD, you start to feel very sad, helpless, frustrated, angry about how it's impacting the rhythms and routines of your family. You can feel very guilty as a parent that somehow you created this or caused this, or guilty in your reactions to them. So easily, as parents, as spouses, we can push too hard. We can become impatient, yell, sometimes punishing them. We start to push them away to some degree, not be able to understand where they're coming from. Or we swing a little bit the other way, where we try to help by allowing the rituals or avoidance, that accommodation piece. We try to protect our families members by fixing things for them rather than having them do it for themselves. Often there's a sense of walking on eggshells and being afraid to upset or trigger a family member. We try to keep the peace. And in doing all of this, often there's a sense of feeling lonely and isolated and that no one understands, which is typically a parallel to what the person with OCD is feeling as well. And you're kind of sucked in and caught into that same bubble with them. So how do families accommodate OCD? Well, what ends up happening is that family members end up participating, assisting, or facilitating the compulsion. An example of this is perhaps your child is going to bed. You sit down on their bed to say goodnight to them, and they suddenly say, oh, now my sheets are contaminated. I can't sleep in this bed unless I clean my sheets. So suddenly you're stripping the sheets off the bed. You are putting new sheets down, making sure everything is fine because you just want the kid to go to sleep. But then we've reinforced the sense that their fear, their intrusive thought that there was germs is valid and that the compulsion was necessary. But it's very understandable because, gosh golly, you just want this kid to go to sleep. Other times we modify family routines. We excuse them from expectations because the compulsions are taking too much time in their day and they can't accomplish other tasks. This is a common one in partnerships or marriages where one person just ends up taking on more and more. This needing for excessive reassurance, continually texting throughout the day, needing to hear you say things in a certain way, that it's okay, that everything's all right. That's a big one between parents and kids, especially teenagers. Perhaps you start to modify leisure activities. You don't want to do a certain activity because it might set off the family member. Changing work schedules. This is another really big one. Maybe you start later in the day so that you can get your child to school after they've completed their rituals. And I want to note, if you are a family member and you're seeing these items on the list as something that you do, I want to take a moment and just express these are very natural and normal ways of how families respond to OCD. You don't need to feel ashamed or embarrassed. You can understand that the pressures that families face in trying to figure this out are significant. And so while they aren't helpful for someone with OCD, it's very difficult to do it differently if that person is not getting treatment or if you as a family are not getting support to do it differently. So how can we help someone with OCD? Well, this is hard, but like I said, the treatment provides quite a relief of being able to have more freedom in their life and not to carry that level of distress all of the time. So how can you help? Well, like I said, trying not to engage in the compulsions at home or enabling them. Trying not to do that accommodation, changing and modifying all of those kinds of pieces. Having an understanding of what your family members' compulsions are, and then trying not to engage in them, and rather finding ways to step back from the compulsion, which then leads to you tolerating the distress from the other person and tolerating your own distress, which is where some of those other skills come in handy. And I understand this is particularly distressing when you're a parent and you're dealing with kids. And so I can understand the challenges with that. So the next one is encouraging the person to seek out treatment. This is particularly with couples. Often people with OCD do not want to seek treatment. There can be a lot of shame in what they're experiencing, and they don't want to expose that to people. Rather, they just want everybody to accommodate them. So you have to remember that they get very significant relief after doing the compulsion. It just brings everything back down. But it's also then making it stronger and stronger. So encouraging treatment and then also getting your own support as a partner. If they seek out treatment, as a family member, you can support the work of the therapist, such as helping them facilitate those ERP experiments at home. So maybe that is providing the exposure items that are necessary, maybe creating time in the family schedule for these exposures, setting up the scenario, being able to come alongside them. Another acronym here that's used for the parents for working with kids is RALI, which is the R Recognize OCD episode. Oh, this is what's going on. Oh, this is OCD showing up today. Then you ally with your child. You come alongside them. They're not the problem. You're not there to punish. You're not there to get exasperated. You go, oh, this is OCD. This is what's happening. I'm coming alongside you. Then you lead them to that ride, that up and down the worry hill. We're going to have that increase and then come back down. And then you're going to let go, the second L, so that they can learn to do that on their own. Okay, here's what we're doing. Go up, go down. I'm just here beside you. I'm going to let you do it on your own. And then Y for yes, which I think is a little bit lame, but yes for bravery, rewards, praise. Hey, you did it. Good job. We can do this again next time. As a partner of somebody who has OCD, you're going to be doing less of that facilitating, but you want to cheer on their success. You want them to be able to talk about what OCD is like for them in an open way, celebrate the wins when they do resist their compulsions, when they are managing things, and reminding them that you don't view them through their intrusive thoughts and their consequent behaviors, but rather that you view them for who they are. So, different supports for families. In my mind, I feel like it's often very important for family members to have their own supports in addition to the person getting treatment. So OCD impacts family members in lots of different ways, and there can be a lot of variation in how it impacts you. It can be very hard to live with someone experiencing OCD. There can be a secretive element where you feel the need to hide the OCD symptoms to protect your family member from someone else's scrutiny or critique at times. As families, sometimes we create these cover stories where we, if we're late attending a party, this and this happened because you were actually late because the individual was engaging in their compulsion and that was time consuming and you couldn't get them out the door. But we don't want to say that. And so we've come up with these cover stories, right, to make it easier. But then that also creates isolation for you as individual family members. I find that when you seek out support, sometimes in these group settings as well, you can be more honest in what you're experiencing. There's a safe space for it. You feel much less alone in the experience. You start to hear, oh, other families go through this as well. It can help to reduce those feelings of helplessness or blame that sometimes come up. I have a family I know of where one of the siblings had OCD, and it was a contamination OCD, and they strongly believed that their sibling caused contamination in their home, and so they wanted to restrict where their sibling sat, what their sibling could do, how close they could be to them, and really viewed their sibling as a source of contamination. Obviously, this sibling who had OCD needed to be able to engage in treatment and to lessen the intensity of those. But this other sibling who was viewed as being contaminated also needed their own support to be able to understand the impact for them, how they were viewing themselves, how they viewed their role in the family, and really getting a lot of support for that. You can hear how hard that would be for the other kid as well. Sometimes family therapy where you're all together can be helpful, but not always. It just kind of depends. And again, as I mentioned, support groups can be that space where you feel, okay, other people get this, other people are experiencing this too. If you do seek out therapy, I would encourage you to take an extra moment or time to ensure that the therapist or the psychologist is specializing in OCD and that they're following gold standard treatments. So supports for individuals with OCD and their families. Our clinic here at the Family Psychology Place, we have NIHB providers approved across the lifespan. We have Flourishing Futures and FSCD approved providers as well. Dr. Cheryl Gilbert McLeod is a specialist in this area, and she sees children under the age of 18. I see adults over the age of 18. And really, we're open to having to be able to provide that support to the different family members, stuff like that. In addition, Alberta OCD Foundation is excellent. They have an online caregiver support group that's available. Anxiety Canada, that was the website I got some of my resources from. They also have support groups available. In particular, I wanted to highlight parents of adult children with OCD. This one is also a complicated relationship because it's no longer that direct parenting, and perhaps they're living with you, but there's less influence and say. It can be very distressing. So that's a really specific one that's great. There's also the International OCD Foundation that's available. We have just a list here of different literature suggestions. The OCD book that I used to take the example from Mike is that second one with John Hirschfield. Just good resources that are available. So that concludes my presentation for today. Thank you for your time. This was just kind of a general overview. I appreciate everyone being present, and I hope this was valuable for you.